and Infrastructure Work Group meeting. We got a lot on the agenda. So just a few housekeeping for the work. Okay, for the work group members who are online, you are unmuted. So please self-mute on the GoToMeeting console so we don't hear some background noise. But whenever you're ready to speak during the meeting, you're free to speak up whenever you please. The rest of those folks who are participating online, you are muted, and so we'll be waiting to the end of the meeting to get your comments and questions. Also, for the folks here, please speak into the mics. Some of us are a little quieter than others, and so for those people who are on the phone, and then also for people who want to listen to this recording into perpetuity, we need to be able to hear the voices. Okay.
All right, let's start again with the short introduction so everybody knows who is on the online and who is around the table. So we'll start from this side.
Hi, I'm Amanda Vaughn, and I'm with the Health Services Cost Review Commission, and I work with the monthly data and annual data.
Hi, I'm Linda Bartniska from the Maryland Healthcare Commission.
Ben Steffen from the Maryland Healthcare Commission.
Doretta Lee with the Maryland Healthcare Commission.
Lara Spicer from the Hilltop Institute. I'm here with Medicaid.
Trisha Roddy, Director of Planning for the Medicaid Program.
Tracy Laval from the Maryland Hospital Association.
Raquel Sampson from DHMH, Health Systems and Infrastructure Administration.
Frank Campbell, Cigna HealthSpring.
David Horrocks with CRISP.
Oscar Ibarra, HSCRC.
Dennis Phelps, HSCRC.
Claudine Williams, HSCRC.
And the ones who are online, if you can introduce yourselves.
Steve Johnson from the Loon Group.
Kathy Talbot, MedStar Health.
Mitch Lomax, St. Agnes.
I also know that Claudia is on the line. Are you unmuted, Claudia?
You may not have a microphone. So,
okay.
If you have any comments, you can also type in. So we'll have Nick King.
Claudia should be on there now.
Okay.
Oh, she's self-muted.
Okay, so you can either speak or write your.
Yes, we do. Thank you.
Okay. Sorry, I didn't. I didn't realize I had to use the function on the webinar thing, so I figured that out.
Yeah, we are all figuring everything about the webinar.
Sorry about that.
No problem. So what we kind of put the agenda as, recap of the discussions that we had from the first meeting and highlighting the data needs that HSCRC has. And then we are going to go quickly to the panel presentations. We have very interesting information from each of the institutions represented in the panel. And at the end, we're hoping to have more detailed discussion on the total cost of measure, which was one of the data needs that we have immediately with the new waiver. So I'm going to have a few slides on agenda number 1. So we had distributed a more detailed list in the first meeting, but this is in terms of how we group them and in general what the buckets are. So in the performance targets, in general, these are our per capita measures for Medicare and all payer and quality targets. And the data sources here are defined pretty much securely that we will be using Medicare claims and HSCRC data set for these calculations. The guardrails are the ones that we will be monitoring, and if we trip over certain percentages, then we will have a corrective action plans with the CMS to identify the problems and then address them as we go through. So these are also coming from Medicare claims and HSCRC data mainly. Then we have compliance data group where we have to monitor certain I would say, system factors and monitor and report to them annually to the CMS. And again, they are coming mainly from Medicare claims and HSCRC data. The only information that we need to collect new in this category is the shared savings amounts from each hospital, and we will be working with the hospitals to find the best way to collect that information. The monitoring data is the one that we need a lot of new data sets, because monitoring is not only the hospital piece but the overall healthcare system. And in addition to that, the measures include the population health and patient experience of care. In the monitoring section, the needs that we have is in the two buckets. One is the patient experience of care. We discussed in the last meeting briefly these 4 elements that were listed in that big list. The first one is discharges with primary care physicians identified, and we discussed briefly about the options we have. Maybe we can leverage the information from Chris, or we could have a question included in our discharge abstract, whether if hospitals can identify the physicians or not. We'll get to more general discussions in our 3rd meeting before we write our final report on these. The other 2 related items are the participating physicians in Medicaid and Medicare. And again, we discussed several options there, which I'm going to get to shortly. And the 4th item is the participation of providers in what we call alternative, innovative payment strategies, including medical homes, ACOs, and bundled payments. The discussion we had, I tried to summarize it, but I think there was a consensus in the last meeting that we all agreed the claims may not be the appropriate way to look at the MPIs, because they tend to report the entity that is billing, or we have issues with the practices. So it wasn't really, my understanding is from the comments you made, the claim information and the MPIs on the claims will not be helpful to count number of physicians participating in these programs. And I see some heads nodding, but we are, this is still kind of a part of the discussion, but probably we could all agree that the claims is not the first place that you would go. We'll look for other mechanisms to get this information. And then we discussed a little bit on the payer-specific provider list. Medicaid mentioned they do have a provider file that might be useful. Medicare has some information on their website on physician MPIs, especially ordering certain procedures, if I remember correctly. And then we do have a Board of Physician database. So in the next meeting, we are going to have more detailed descriptions and evaluation of these alternative sources. And if you have other sources, please feel free to email me or Claudine, and we'll put that on the agenda for the next meeting. On the healthcare cost bucket, on the monitoring one, there are some outpatient utilization measures which are currently calculated by Medicare. So we need to find a way to calculate them using Medicaid and private payer claims. And these are certain procedures ordered in the outpatient setting, and the algorithms are already prepared. So it's a matter of identifying the data source that we can use and create the all-payer measure equivalent. The other 2 are the per capita hospital expenditure growth. So overall, HSCRC has the hospital expenditures from our data set. What we don't have is the enrollment information if you are doing a per capita calculations for specific payers. So we would need to have Medicaid enrollment numbers. We would have Medicare from CMS, and we would need something from the private payers for the denominator calculations. The 3rd one, which is our focus for this meeting, is the total cost of care measures per capita health expenditure growth. And here I identified 2 options. Mainly, one is using the medical care database, which includes the private insurance claims, and supplemented, and I'm sure they're going to talk about their plans, with the Medicaid and Medicare claims information, so we can get the all-payer total cost of care calculations. The other option is to have payers and to submit an aggregate level reports for not only calculating the total cost of care, but also looking at the shifts in services. So, if you have detailed buckets, you may look at the increase in physician cost versus hospital cost and vice versa. And in the in the last section of our meeting, we prepared a template based on Medicaid reports to start the discussion on if we are going to go and try to collect aggregate level reports, what level of detail that we need to address the needs of the waiver calculation. So here, I guess my kind of take-home message is that we are not interested, well, we need a single number, right? We need the total cost, but for us to be able to use those reports, we need more detailed information so we can understand the trends and factors underlying that one number. It will be easy to just ask one number, I think, but that won't be sufficient for us. So going back to the main presentations of today, I kind of tried to draw a diagram representing the architecture of the data sources in the state, and we do have very dispersed sources. So every commission, every agency collects the data sources that they mainly need and then collaborates with each other for the data exchange. So we have the HSCRC, which has the hospital data. I should add here the Medicare claims data, which is going to come through this process. We have the DHMH here, mainly going to talk about population health data, but they do have other collections as well. And MHCC, I group them as quality of care measures, utilization, and cost data that they have. And finally, Medicaid, that provides the enrollment and utilization and provider data to it. And I put Chris in the middle of all these things because through their unique algorithm, they have an ability to link all these data sets if need arises and if the information is there. And they've been really instrumental and critical part in HSCRC work, especially on our readmission work, to be able to create those links and be increasingly looking into, whenever we have a project, Chris has been very, very helpful and instrumental in linking our data sets and getting additional information for our analyses. And also the other two areas that Chris is also very important are the provider reports that they produce for each hospital and also the clinical information that they collect and the ability to connect the dots in the system. So with that, I'm going to jump to the first. Yeah, go ahead.
Good question. Back one slide. When we were talking about the per capita hospital expenditure growth, I was always thinking of that as we would want to know the that growth in total, and maybe even split out Medicare and all other payers. But I think what I heard you talking about for the hospital growth and for the total was looking at total and then Medicare, commercial, and splitting that out. What's the thinking behind that?
So that's in our monitoring list. So if you, for our, let me go back even. The 4 buckets that we have, our total hospital cost per capita is in our performance targets. Right, it's on HSCRC, and if you go back to that detailed list, you'll see that it's the demographic information coming from Department of Planning, just in the number of Maryland residents. Right. In the monitoring bucket, in the last one, we are going to be breaking that number by payer. There, we are looking at the Medicare, Medicaid, private insurance as separate buckets for monitoring and reporting purposes. So that's kind of, they are related, but the performance targets ones are not divided by the payer, but the monitoring one is. Okay. And it's both for hospital and also total cost of care.
Okay, I didn't realize that.
Any other questions on the recap? All right, so with that, I will. The first presentation is the shift measures, and Raquel Sampson and other, do you have, if they can come join you, yeah, and if you can introduce. Oh, okay. And
Thanks.
And somewhere over there.
Perfect. Dive it towards the floor. Oh, there you go. All right. All right. Good afternoon, everybody. So we're going to try and make these as upbeat and lively as possible so we can get through these presentations pretty painlessly. But we are really happy to present on the state health improvement process. With me today is Katie Kanasevich, and she is our data analyst who oversees the data collection for our SHIP measures. And she'll chime in as need be. So what I just wanted to do is give you a quick overview of what SHIP is and the purpose that it plays. We have some key visionaries and measures, and then how these SHIP measures, the population health data, will be the ones that have been selected, and we can discuss how that happened and didn't happen, because I've been trying to dig around and find out how that group was selected, but how that applies and how they might be used, and some thoughts moving forward. Towards the ground. All right. So these are just kind of the beginning slides. I think many of you know that DHMH has a fairly new, we've reorged, and we have a fairly new administration called the Health Systems and Infrastructure Administration, and we're really thought to be sort of the intersection between public health and clinical care, and sort of where that all merges together. And the only reason I start the presentation with this graph is this is a study done by CDC that really talks about what it is that we need to do to lower cost over time. We know that coverage is one piece, and we know that coverage plus access, so if you look at this graph, the red line here is once people get coverage, what happens over time with cost. And what happens over time with the blue line is really what happens with coverage as well as access. But this study sort of modeled out what happens without these sort of community interventions if you don't have those that deal with behavioral health issues as well as environmental sort of interventions, which is what they called protection. You really need those to lower cost over time in the long run. And that's really sort of an illustration of what SHIP is meant to do, is really to bring together under some population health metrics to engage not only clinical providers but also community health providers and other health providers to improve health over time and reduce costs. So we talk a lot about the social determinants of health, and none of this should be any news to anyone, but we know that healthcare impacts a certain amount of a person's health over time, but that there are other issues that also impact on those days that we aren't seeing the clinical provider that we need to be helping to support people with behavior change, environmental circumstances, and also their social circumstances. And so there's a lot of different things that are going on in this state during this time of change in the healthcare environment. 5 key components that we talk a lot about are promoting access to care, promoting wellness and community health through public health and medicine integration, access and addressing population health disparities, reform incentives at the hospitals, which is why we're here today, and using mapping and hotspotting to really address some of the specific needs through primary care and community outreach for populations that are our highest utilizers. So how this all works, okay, I'll just keep diving it at the floor. There we go. So the health improvement process is really what we think about when we start talking about how to promote wellness and community health through public health and medicine integration. So in 2011, and a while before that, but 2011, the state health improvement process was stood up as a framework and resources to align local health action to continually improve population health. And currently we have 20 local health improvement coalitions, which is really the on-the-ground mechanism by which we view communities working together. And in some cases, there are health departments are involved, co-chairing with community-based organizations and hospitals. And there's a lot of variability. And right now, we have a lot of variability among the local LHICs. Some are very sophisticated, have had processes long before the advent of SHIP, but also some are really struggling. So we want to make sure that we bring all boats to float and are working to support their infrastructure. So we have 41 measures that are collected at the state level, and then there are also those same measures are broken out by jurisdiction. And we had baseline set for 2012 to 2014 with 2014 targets. And some of the data measures where we do have data are broken out by racial and ethnic demographic information. So this is what the 20 LHICs and where they are. We have one regional LHIC on the midshore, but this kind of gives you an idea that every jurisdiction has a local health improvement coalition, excluding the midshore that has a regional local health improvement coalition. So what do we use the SHIP data for? It's really to assist priority setting and identifying community health needs, and to get sort of all boats rowing in the same direction to try and improve community and population health. And that we really look at this as an accountability process as well. I think many of you may or may not be aware of the Public Health Accreditation Board. This is a CDC-driven accreditation that local and state public health departments are seeking, and it is rumored that funding will be tied to that. So this idea of continuous improvement is really critical. So the SHIP measures, there are 5 vision areas, and they're listed here, and there are 41 measures that are part of each, 41 measures, and then they're broken out by the vision areas. And rather than go through each one of the vision areas and all of the measures, I think we have a handout that you all have. And this is our 2013 updated list of measures. We use this as a report card every year to allow statewide folks to look at where we are with our little green, yellow, and red key, and then our little hourglasses for areas where the data hasn't yet come in. So through the vision areas, each section of the vision areas has 8 to 9 measures, and you can read those. And how we bring all this information together is through a website called Network of Care, which will be publicly launched in the next few days. We have the ability to bring all of those measures together statewide, but then each local health improvement coalition has the ability to look at their measures in comparison with other counties and in comparison to the state and the nation. And we have a website, so you can go ahead and look at that at your own leisure. It links together best practices and also provides an interactive atlas to be able to understand some of the nuances of where things are going well and where your county is ranking with the rest of the state. Now, for the purposes of the waiver, this is not meant for you to be able to read. Okay, so first of all, that's not the purpose. So the second handout we gave you lists the data sources. So all of the data sources for the SHIP measures come from other data sets. We do not collect any data in our office. They're all secondary data sets. And we have a definition, a list of, does everybody have this? Do you guys have it? Do you all have it?
I think it was handed out.
There's a few more copies. So if you didn't have the slides or you don't have the handout, this sort of goes through all of the different measures and provides the data source. And when we collect that information, oftentimes we collect it from the source or the group that puts it out, and then we post it and pull it all together collectively. And so in regard to the monitoring using population health data, we didn't want to limit it only to the measures that were part of the handout that you had provided, because I think there might be some question about which measures we use and which or discussion around that. So we just wanted you to have one place to reference, and we can give this to you in whatever format you want, how and when, or what measures are available and when they're available for each calendar year, and how that would relate to monitoring for the waiver. So, for instance, the first one listed is students who graduate with a high school, graduate from high school, MSDE. That might not be one of the measures that we use for this purpose, but we left it on there just so you would know the breadth of what is available from our data. Now, specifically, the spreadsheet that you all provided us, HSC provided us at the last meeting, you listed a number of measures that were potential measures to be used in the monitoring and data set. What I went ahead and did is updated the measures because the original set that we had for 2012 has been changed a little bit, so we added a few and took a few away. So I just updated it with the number, the SHIP measure number that is the most up-to-date. And then I think when we started looking at this, we thought there would probably be some discussion around what would be used and what might not be used. Life expectancy is the first one, and I don't know in the next 2 years if we're going to make a huge change with that and if we want that to be one of our monitoring measures, but that's an example of something we might want to discuss. Mm-hmm. The other issue is that many of these come from HSCRC, so you know how that works, like PQI, for instance. I know that we calculate, Katie calculates PQI quarterly, and looking at that on some regular incremental basis, and who collects it and who needs to be collecting it. I mean, certainly if it's already being collected, we don't need to duplicate it. The purposes of us pulling it together are different than the uses for the monitoring, so that those are all sort of questions that we had. And this is our contact information. So I think we're waiting for questions at the end. Is that the idea?
Right. If there are any quick questions to Raquel, you're welcome to ask now. Or once we have all the presentations the links may emerge between the two sets. I just wanted to comment on the list that we distributed. So that list kind of came through the process of our application when we discussed this with DHMH and the SHIP process, and those were kind of selected on a preliminary basis. The intention is to take that list to the performance measurement work group and then evaluate them and see the relevance given the most application that we had, because we had 2 applications for the new waiver. One went last year in March, and then we revised it and sent the second application in October. So given things changed since we created that list, the performance work group is going to take that list and try to see which ones are more relevant and maybe create the ones that are more important and the others more on a monitoring basis. So that information is going to come to you again, I would say mid-April or end of April, for you to look at that list again, and then given the presentations we have now, again, think about what are the gaps and what is the direction that the performance work group wants us to take in terms of evaluating the system performance and hospital performance.
And I would say just because we're already collecting all of these, the data from these different measures and putting them all in one place, certainly we can continue to do that, and whatever increment makes sense. So.
I have a quick question. On the that list of metrics to monitor, are there certain metrics that you think are non-negotiable that are definitely going to be on that list, and others that are maybe not?
Yeah, I don't really know. So this is a kind of our side of the story. The CMS side of the story is that they are trying to reconcile their measures for ACOs and others and create a unified measure list. So we need to link up with that list too and see what that list is and how much overlap we have with our list. So and the cost measures, I would say, since they are linked with the actual targets, are probably non-negotiable. And also the 3-part aim, it was linked to that 3-part aim. You have to have measures in all of them, and you have to go beyond hospital. So those are the things that are kind of driving that list. But in terms of individual measures, I am not sure. We kind of will see. But my sense is that list can be modified if we justify the rationale and then put a good framework around it. All right, so we'll move to the second presentation. So that will be Medicaid with Tricia and Laura.
I'm Tricia Roddy. I'm the Director of Planning for the Maryland Medicaid Program, and I have Laura Spicer here with me, who works with the Hilltop Institute. For those of you who are not familiar with our structure, we've had a long-standing relationship with the Hilltop Institute going back since 20 years or so. It's been a really long time, and they get all of our data that I'll be talking about today, and they provide analytical support for the department. So today, I'm mostly talking about our Medicaid management information system. I'm going to touch upon some other tools that we use to measure total cost of care as well. But for the majority of the presentation, I'm going to focus on our claims processing system. Oh, so I can't move this? No. Okay. I guess if do you guys all have handouts so I can just work through
Yeah,
this?
I can also move it from there.
Big page 3, big page 2, little page 3, just to give you a sense of how large the Medicaid program is in Maryland. We're covering over 1.1 million Maryland residents today. We cover now since January 1st, 2014. We cover adults up to 138% of the federal poverty level. We've covered children at a much higher level. We cover them up to 300% of FPL. Pregnant women, we cover them up to 250% of FPL. And then we have individuals with disabilities, and we serve the elderly as well. Those are generally our major population groups. And as you know, you all are reading the paper, Medicaid is growing at an enormous rate these days. So we're well over 20% of the population in Maryland. We provide, I would say, for all of these populations now, we're providing comprehensive health care services. So not just acute and physician services, but we also provide long-term care supports and services to these individuals who need them. Unique to other payers, we have two different systems. We have a managed care system as well as a fee-for-service system. 80% of our population is served through our managed care program called Health Choice. And some of those individuals receive certain services outside of the managed care program on a fee-for-service basis. And we have, right now, we have 7 MCOs serving the Health Choice program, soon to be 8, probably later this spring. To give you a sense of our MMIS in terms of what we house in there, we get both managed care encounters and fee-for-service claims. We have eligibility and demographic information for all Medicaid participants, capitation payments to MCOs, and information about Medicaid participating providers. So our MCOs are required to send to us encounters, which is essentially claims information on their enrollees. They're supposed to be sending them on a monthly rate. So we have all the services that the MCO is providing to their enrollees. We track that. So I'm on big page 3, little page 5. Again, as I explained, we get the encounters from our MCO recipients. We have institutional, inpatient. We have everything that you would expect that a payer would have in terms of claims. So if you're thinking about what you might be able to produce in terms of access and utilization using Medicaid data, think of what you can produce from claims information. You can look at dates of services, you can look at procedure codes, and you can look at diagnosis codes. We have the individual's name and Medicaid ID, so we can look at the services that are provided to an individual within a year, longitudinal, if they've been on the program for multiple years. We also contain eligibility information. So again, we have information on the name, address, date of birth, gender, race, ethnicity, social security number. You know, the address has never been the greatest field. You know, we've got a population low income. We've got people who are moving residences on quite a bit. For the most part, we've got a Medicaid ID number, and we can track them that way. So little page 7, big page 4. Again, 80% of our population is under a risk-based managed care program, so we're paying capitation rates to these members. We send out monthly files to the MCOs. We have a very comprehensive rate setting system. We use Hilltop, and we use an actuarial service to develop these rates. It's based off of the Johns Hopkins rate setting system, risk-adjusted rate setting system. So we have multiple regions. We set rates based on age and sort of major category: children, families, disabled individuals. But we have thousands and thousands of different rates. Which I'll touch upon a little bit later, we don't just use claims information to develop capitation rates. We require the MCOs to fill out what's called a health financial management reporting tool that captures very detailed information across their members, across various service categories. And that is the major tool that's used to set capitation rates. We use claims encounter to figure out sort of how we might divide up the pot of money in terms of risk adjustment, but in terms of setting the actual rates, the major tool that we're using is called the Health Financial Management Reporting Tool. As I mentioned to you, we have provider information. We have all the providers who are participating in our network, as well as the MCOs. The MCOs must send their provider files to us on a regular basis, and if there's changes to their provider network, they must let us know. So we have all of that information, and we're required by CMS to do our own kind of network adequacy reports. We do pretty standard reports looking at a kind of a per enrollee ratio, mostly at the PCP level, but we're required for our program to monitor access. Little page 9. Again, we're serving a tremendous number of people now in the state. We have over 30 million records processed each month, 5,500 variables, and we've been keeping data since 1997. So again, it's just the size of our population and program now. Again, as I mentioned earlier, we have this long-term relationship with Hilltop Institute. We send them, I think it's monthly files to them, so they get everything that I'm talking about today, and they're able to generate all different types of analysis for us using that data. So some of the strengths, we can do, again, everything that you can think of with using claims. We can look at cost, service utilization, provider network adequacy, enrollment trends, and access to care, and quality of care. So again, we don't rely solely on MMIS2. There's other different reports that we use, even on the quality side, where we do surveys, and we do, we require the MCOs to participate in HEDIS. But in terms of doing our major evaluations on access and utilization, we're using MMIS2. The next page, the major limitation, and I think it's, this is just, it's not a limitation of our program, it's just how providers bill for services. they're required under MIA law. They have 6 months to bill a payer. They have longer to bill under our fee-for-service program. They have up to 12 months. So you can imagine what the run-out would be when you're looking and using this data. So again, it's the same limitations that apply to other payers apply to us as well. The major kind of limitation, I don't know if it's listed on here, in terms of when we get the encounter data from MCOs right now, we don't get their priced information. So we don't get what they paid for the service, and we don't get whether it was paid or not. So we have developed over time, most of our analysis, we do a workaround where what we call shadow pricing, where we use our fee-for-service price levels and charges prices to basically determine how much was spent in the Medicaid program under our MCO program. That's going to all be fixed in our new system. I know you've all been probably aware that we are building a new MMIS system. We're looking to have that ready towards, I think now, the late 2015, so it's not here today. But the new system will be able to capture price information. And then lastly, I just wanted to mention that we are participating in the all-payer database that MHCC is putting together. So we plan on sending all of our information to that database that they're developing.
Thank you. This is really the right level of detail that we were looking for, so we get a better understanding of the data that you collect and the strengths and limitations. So I learned a lot already. All right, we have MHCC, Maryland Healthcare Commission next, and Ben, Stefan, and Linda is going to be, and Teresa Lee.
Oh, I'm sorry. I had a question about the claims data. So with the claims data, with the medical record numbers, is it possible to find out, like, across multiple vendors if it was for the same medical record or for the same person? Because I think for different hospitals and such, they have different identifiers.
If you're asking me, Tricia Roddy from Medicaid, we use the Medicaid ID number. So we're not looking at your hospital ID number. So I know you guys, it's one of the limitations of the HSCRC data is that you can't track it right now across hospitals. Within our claims processing system, we can look across hospitals. We look outside Maryland hospitals. We track all the services that are provided to an enrollee, and we can analyze it that way. We can't analyze, of course, if they move on to a commercial insurer or across payers, but when they're in the Medicaid program, we can analyze and look at the data.
Thank you.
So I think we're ready. Now we have to follow Tricia, so I hope we do as nice a job as she did. I think we were asked to give some very general information about our databases so that people who are unfamiliar with them would have some idea of what's in them. And then to move specifically to some of the monitoring measures, or in Teresa Lee's case, there are quality measures that have already been determined that they'll be providing so that you can see what we could give. Okay. So the first slide is just a little presentation overview so you don't get lost. And Ben's going to present the first slide on MHCC data structures. Then I will do a discussion of the Maryland Medical Care Database with little description, some file details that might be pertinent to some of the measures, and then actually go through the monitoring measures that were listed, and can we do this or not. And then I'll turn it over to Teresa, and she will talk about Maryland Hospital Performance Evaluation Guide and the Maryland Quality Measures Data Center. So, and oops, sorry, I got.
Back it up by one.
There we go. Thank you.
Thank you, Linda. So I thought it was important to maybe lay out the overall structure of the Maryland Healthcare Commission's data systems. You'll note, if you look at that, and I hope all of you can at least sort of make out what those boxes are, that there are 4 systems and 1 database, which that was by intent. Really, when we think of our data, we think largely of the systems that they are designed to serve. So as many of you know, performance has been a key issue for the Maryland Healthcare Commission, starting initially with health plans, moving into nursing homes, and shortly thereafter, in the early years of this century, we added hospitals as well. So our focus has been on putting together what we conceive of information needed to judge performance, which means we pull together information from a variety of data systems. The health plan system is the one that I think we view as the sort of the anchor for what we've done with hospitals and nursing homes as well. It includes claim data composed by carriers, largely derived through their administrative systems from which HEDIS measures are developed. Most recently, we're adding some race and ethnicity, language and cultural competency measures that will come from plans directly, largely from their administrative systems. And the third element of that is our enrollee satisfaction measures from CAHPS. You'll see CAHPS appearing in a couple places here. So that makes up our performance system for health plans. I'm going to jump over to the hospitals now and then come back to the MCDB last. But the hospital performance guide, similarly, core measures from CMS, patient satisfaction, some utilization data is brought together, and I'm sure many of you are not surprised. Some of that does indeed come from the hospital discharge abstract. What's, I think, sort of unique about the hospital performance system is the wealth of clinical information we've been able to bring together from other independent data sources. The National Health Safety Network, a system monitored by CDC. We conduct some of our own surveys of hospitals to judge hospital flu vaccination rates for our clinical, for our infection initiatives. And soon we will be adding cardiac registry data from information systems composed by the American College of Cardiology Foundation, I think they like to say, that provides some very detailed information on the performance of physicians and hospitals that offer our cardiology services in the state. We plan to add soon some additional information. These will be driven by regulations potentially through that have not yet passed that will cover thoracic surgery results too. This would be cardiac surgery results that longer term we would be adding. Our long-term care performance system, again, similarly, we think of this as a suite of information gathered through administrative systems. In this case, it's something that has been developed by the Centers for Disease Control, for CMS, the minimum data set for nursing homes that provides the core for our quality measures, measures that are required by CMS, as well as indicator measures that MHCC has developed over time. A satisfaction survey for nursing homes is a little bit difficult to execute, and to date, CMS has not launched a CAHPS-like survey for residents of nursing homes. Neither have we, but we have a family satisfaction survey that we've implemented about 7 years ago. That's been quite successful in engaging the family satisfaction with care rendered to a loved one in a nursing home. Both the hospital and nursing home websites, I think, are very robust, and we are looking to improve that dramatically. The medical care database is a database that we're really thinking of how that evolves into supporting different systems, professional service, reporting on professional services, supporting the waiver use in furthering the development of patient-centered medical homes in the state, and as Linda will tell you, rate review as well. It is really quite a complex system in that it represents submissions from over 20 different submitters today. That will grow to 30 shortly, but in terms of file constructs, it really represents 5 different types of data elements today, and 2 to be added soon to enhance this data system. As you're thinking about this, keep in mind, I think Tricia probably would emphasize this as well, that this is a fairly complex data structure in that it captures utilization, and that utilization reflects a good deal of variability across the native carrier submission systems. We have to remember that over the past 10 years, there's been enormous consolidation. Our friends from Cigna here can report on that. They've acquired several different carriers in that time frame, as have others. As you move through these efforts, you find out that the actual data processing systems can sometimes continue to exist long after those mergers have reached fruition, and any one carrier is actually submitting from multiple data systems. So it's an enormously complex process in bringing data, in some cases, from 5 or 6 systems from one carrier together in their submission, and then grouping it with everyone else's submission. So it's a fairly complex enterprise of data reconciliation. The last, I think, pretty important data set of buckets is the information we use for our regulatory oversight. That might mean, for those who are intemperate, our oversight through the Certificate of Need program and health system planning. We host a variety of surveys, professional surveys on nursing homes, hospital and hospices, home health agencies. We have our cardiac regulatory data, which is used in the health plan hospital performance guide in that bucket as well, because we use that for health planning, determining the need for additional cardiac services in the state. And we also count in this bucket information that we collect in collaboration with the boards, in particular a physician survey that's done in conjunction with the renewal process that physicians go through biannually. That survey originated with very modest aims, but is I think turned into a survey that we're extremely proud of. With the work that the board has done along with us is pretty significant. And recently, one of our contractors, which happens to be also a HRSA vendor, commented on if every state had a survey of the complexity and extent that Maryland had, HRSA would be far better able to conduct workforce planning in the country. So we're continuing to take that forward, and over the next several months we'll be working with other occupations. Nursing, pharmacy, dental are some of our initial boards that we are particularly interested in, to build out surveys of probably not as much complexity initially, but of some complexity, particularly to capture information on where providers are actually delivering care, to further some of the workforce planning that's being done at HSIA and other organizations here in the state. Lastly, a couple points on common themes I think that I would emphasize in the development of the systems and even of the database here is that we've developed it through tried to focus on multi-purpose data systems, a focus on collaboration. It's the old PTCA model in a sense that we engage the industries, plan, test, give them opportunities to review and make certain that information is accurate before it is published. We emphasize auditing of the results. All the performance guides have a heavy dose of review, and I think that's going to be very important as we think about using measurement and capturing and estimating total cost of care, that what is reported is accurate. We are the first state that I know of that has actually identified and awarded a contract to a vendor to audit our APCD submissions from the private carriers. That contract has been awarded, but the auditor is yet to go into the field. But I think auditing is extremely important if you want to have very clear results. And lastly, we started small and developed grew over time. I think my own preference is to think grandiose, but I have practical staff members around me that remind me of what can be done in the short term may not ultimately be the long-term goal. I think that's very important to emphasize. The last point not up here is that there's been a focus at MHCC, but it really goes beyond that, and certainly through the SIM initiative as well, is to focus on measures consistency across quality reporting initiatives. And although this is just in the very early stages at the MHCC, I think we recognize that if we're really going to make an impact on, for example, diabetes, we want to have those quality measures percolating through the health plan performance system, through the hospital performance system to the extent we can, and the long-term care performance system, and through a variety of our primary care initiatives where we would expect ambulatory practices to also be making significant and perhaps the greatest impact on diabetes, for example. But the consistency in measurement, I think, is something that sometimes doesn't get emphasized enough. If you really want to move the dial and you're dealing with measurement across different entities, you have to the extent you possibly can, align your measures across those systems. So I'm sure I used more time than it was allotted, but I'll quickly pass it back to my colleague to my left who will carry you through some of the detail.
So unlike Ben, I'm going to be very focused and really specific. As Tricia said, the Maryland Medical Care Database is in the process of incorporating Medicaid data. We also purchased Medicare data. But since what you want from us with regard to the waiver is our privately insured data, I'm going to talk only about that. And we've been collecting this data for about 20 years now. It started in 1993 when the legislature created the medical care database. That was the name they gave it for our database of privately insured claims. Initially, it was only professional services because in the early 1990s, some of you may not be old enough to remember, but for those of us who do, there was a big uptick in costs, and the legislature actually created this database to be analogous to the hospital discharge database with the idea that there might be rate regulation of professionals. When costs kind of came down, there was some response to the upward tick. The need for rate regulation in professionals went away, and the other alternatives that the database could be used for came to the fore. And so we had our authority expanded so that we were able to collect prescription drug claims along with the professional services. And then in 2007, we got permission to collect institutional claims, which are a little different than it's a summarized claim. I'll talk about that more. And then recent and eligibility information, health plan descriptions, which are in development. And then this year we got our regulations changed to expand our collection to PBMs and pharmacy benefit managers and third-party administrators who serve self-insured employers in Maryland. And also that the submissions now had been annual, and now they will be quarterly. So those are two big changes. The data universe of the privately insured data in the MCDB comes from carriers, PBMs, TPAs that are licensed in Maryland and have at least 1,000 covered lives, enrollees, and they're required to submit. They're required to submit information on enrollees residing in Maryland or covered under Maryland contracts. We think that the database incorporates about 90% of the privately insured Maryland residents. I wanted to point out that about half of the privately insured in Maryland are in self-funded employer plans. Those plans typically carve out prescription drug coverage and also sometimes behavioral health services. And so the only way to get a true per capita expenditure across all your privately insured is to be able to collect the carved out pharmacy claims and then match them to the individual who has the medical claims and combine them together. So, now, let's see. Put this down.
That's the right one?
Yep. Okay, we're good. So this is some of the detail on the claims level data. It has professional services, institutional services with one record per visitor stay as summarized by the carrier. So there won't be a lot of claims for a hospital stay. There will only be one, and it will include the total price. And there will be revenue codes, but not price by revenue codes. I say that because I think there are a lot of hospital people here, and that all makes sense to them. And also prescription drugs. In the institutional service, there are not only hospitals, but any nursing home stays that were covered by the carrier. And so those are the institutional visits. There are not, unlike in Medicaid, we do not routinely collect dental claims. And a big reason for that is if we collected all of the covered dental claims, we would not have a pretty good picture of what dental expenditures are across the entire population, because so much of it for the privately insured population is out-of-pocket spending, and many of them do not have a dental plan. Little important reminders about what's in the claims detail is it's covered services only. So if it was a service for massage, that's not covered by the carrier, it's not there. It's very robust in financial fields because this is the purpose of claims data is payment. That is the purpose. So it has allowed amount, the carrier payment amount, the expected patient payment broken out into co-payment or co-insurance, deductible, other liabilities. It also has several flags, one of which is an out-of-network flag. And I mention that because when you calculate your per capita spending, you have to decide in the privately insured if you're going to assume balanced billing or not. Because if it's out-of-network, we make a total patient liability that assumes balanced billing, but you may choose not to in your data. The provider identifiers are all national provider identifiers, the NPIs, and they identify there are two of them, one for the organization, that's billing, and then there's also a field that's supposed to identify the individual professional who provided that service. The specialty is provided, it is now, we've moved to using a common specialty across all carriers, so we're using the National Taxonomy Code that's associated with that provider's NPI so that it's uniform. The limitations with the data, as Tricia said, there may not be limitations, but they're just what's typical when it's claims data, which is designed for payment. It's not designed for patient management or anything like that. It's designed, it's a payment system. So there's always a time gap between the date when the date of service is rendered and when the date the claim is finalized, you know, and some of that time is however long it takes the provider to submit the claim, spin between the provider and the insurer, and then the claim gets paid. The NPI of the professional who rendered the service may be omitted on the claim because it's not required for payment. You do need to know the organization, so you have the organizational NPI, but the individual provider, you know, may be omitted, or they may have put an organizational NPI in there. And in lots of cases, I know there are some organizations where they use the same NPI for billing. It matters not who rendered the service, but they're going to put that same individual on there. The location zip code for the provider is the address where the payment is sent. So it may not be the location address of the provider. So especially with lab claims, you'll have sometimes the claim will be sent for LabCorp to New Jersey. Now, you know the patient did go to New Jersey for the service, and I think we've actually come up with some ways where we try to localize where the address is, but we know it's not out of state. And then also, at this point in time, test results are not included on the claims, just so, right, it's a payment system. Okay. So this is patient information that you can find in the MCDB. Their enrollment and disenrollment dates and plan information. And by plan information, I mean sort of source of coverage. Was this a small employer plan, a large employer plan in the individual market? It lets us know if it's a family plan or an individual plan. And it contains 3 encrypted unique patient identifiers. One is specific to the carrier and the plan enrollment. So everything that carrier submits will have the same encrypted patient identifier on it. And we have one that we call our UUID, or our Universally Unique Identifier, which is based on SSN, and it's a little black box, and we give it to the carriers, and they put in the patient information and then spit out our UUID, which has been pretty successful, but it does require that the carrier have the SSN that's specific to the individual, which is not always the case, in which case it doesn't turn back a valid piece of information. So we're also, we began testing with CRISP, getting their master patient index put on the data, because we know that they have the ability to assign a unique identifier even if SSN is missing by using other pieces of information. And we will be testing that to see what our match rate is in 2014 from a couple of the PBMs to the medical claims data to see if, in fact, it works the way we hope it will work. There are patient protections in the data, some of them which were mandated by the legislature, that they protect the patient, but they limit our ability to identify the patient. So there are no names. The actual day of birth is omitted, and the patient's location is identified only by zip code. We have requested to get the additional 4 digits so that you can localize within a zip code, but those are the patient protections that create some limitations in the data. We do add some information, and we add it to the claims, we add it to the eligibility file, but for your purposes, some things you would want to know is that we have some normalized variables that we use to resolve inconsistencies across the claims and eligibility file where we say, okay, what's the predominant one? We're going to assign it there, so that a lot of those decisions are already made for you and streamlined. We also have, we put expenditure risk scores on the information for enrollees who have a year of enrollment. We use the chronic illness and disability payment system, which is also used by MEPS in their household survey. Right now I said we limit it to only people with a full year of data because otherwise we're not sure how robust, accurate that risk adjuster would be. But that is available. And then now to get into the monitoring measures that were that I took off your gap analysis. So my consensus was, after looking across the measures, that all of the measures below could be calculated for the privately insured patients using the medical care database, subject to the inclusion and exclusion rules for defining the numerator and the denominator and the information needed to define those rules. So if in any of the rules it required a piece of information that we don't collect, then you would have to come up with some analogous substitute. But that, so I just wanted to make that clear. But off the top of it, it seems to me they're all doable. The patient experience of care, there was one monitoring measure, rate of physician follow-up after discharge. You know, you would have to establish, like, what, you know, what do you mean primary care physician, you know, and what's your window. But if you can do that, then I think we can generate those for you. There are hospital cost and use measures. There are 6 mental imaging efficiency in hospitals that pertain specifically to imaging in hospital outpatient departments, not in freestanding imaging centers. And again, as long as you can, you know, make those analogous rules, I don't think we'd have any problem generating that information for you. The per capita hospital inpatient and outpatient expenditure growth, so, you know, you're looking only for a denominator, and you're going to be getting your numerator from, I think, the cost analysis. I would say you can get the denominator from the enrollment files, but you might, since there's no relationship between the numerator and the denominator, you might want to pick as stable a denominator as possible, and you might want to pick a denominator where you can have control totals, because I know you're not going to want to come up with more residents when you sum all the enrollees than there are people in the state. I'm guessing that's how you're going to want to do it. So it occurs to me that you might want to, for example, use the ACS, which, you know, eliminates it because it does it monthly. People know very currently what it is. It's relatively stable from year to year. You can absolutely use the enrollment files. Carriers do, you know, sort of on the fly change the rules about what they send you, and then we usually find out after we're into analysis and go, what happened here? Oh, well, this year we didn't send you any of the blah, blah, blah. You know, and so that, trying to head that off for you, pick the cleanest, easiest denominator you can find. That's what I would say.
And the ACS is American Community Survey done by Census.
Yes, yes.
They would have Maryland's resident numbers, correct?
Yes, they do. And they're within privately insured. It's not so good because it's a postcard thing. But they have, you know, it's very current. People are really good at it. I think keeps the uninsured rate pretty low. And in total for the private, it might be a good universe, you know.
But it's a sample.
Right, right. So, and that's what I think we're saying, you know, even if I don't, when we'll talk more here about the per capita health care expenditure growth, even though we only have 90% of the Maryland residents, do I feel like it's nice, solidly representative, which is all you really need. You want a representative numerator and denominator. I think that it's, we're really good with this. In particular, I'm going to show you on the next page. We would get the numerator from summing the relevant financial field on the claims data and information eventually on our non-claims-based payments, because you're going to want to add that in at some point. and then the denominator from our enrollment files. And on the next page, I'm going to show you, whoops, sorry, it already went. So we've actually had quite a bit of experience generating per capita expenditures in the privately insured population. We've been working on it for several years. This is an example from the 2012 data. And the enrollees, those are the ends, and these are people who had a full year of enrollment. So I'm just, you know, and these are only for, these are fully insured markets, so it doesn't include any of the self-insured for whom we're missing prescription drug data. So it shows you on here, you can see that it's the mean and the median spending across all the various service categories, no dental, by market, and you can see how consistent this is. We've done it for several years, so I think we know how it works and it operates. We look at out-of-pocket. We do, it isn't shown here, but the expenditures are summed into buckets. And so there's an inpatient sum. We know how much money went to that. We know how much went to outpatient facilities, not only hospital outpatient, but any nursing home or and then I would say imaging and hospital outpatients are included in the outpatient facility side. Then there's all the professional services. We also have created a category where we break out labs and imaging from the other professional services. We've experimented with breaking the professional services into primary care and other, so it can be broken out into other buckets. And then also prescription drugs. And you can see that we've discovered, and then this shows the utilization rates. And so you can see that it's pretty stable. It's about in this population, it's about a 4% of the enrollees have a hospital inpatient stay in any particular year. It's a young population. This is under 65, privately insured. It's not Medicare. And then you can see the median expenditure risk scores from the CDPS. The expenditure risk scores are nice because it's one number, and so you can compare them relatively, across each other. You can see how that works. And I discussed with some people who had a meeting last month about, would you rather use the expenditure risk assessment that they're using for the ACA, and it turns out that about 80% of those people are really assigned only on the basis of their age and gender. So their diagnoses don't enter into that risk score assessment because it wasn't considered necessary that it be accurate at the individual level, just accurate in terms of buckets of money. So that's sort of my overview. We also have experimented more. I promised Ben I would say this. We've done, this is for the people who have a full year of coverage, but we've also experimented with doing per member per month calculations on the dollars, maybe not with the buckets so far, but because you'll want to include everybody, even the people who had partial year coverage or shifted from one carrier to another. So I think we have a lot of that experience. We think that these measures could be, while these are calculated at the market level, they could be calculated at the county level. They could be potentially calculated by someone at the hospital level or for a hospital referral region. But I feel very confident with this because we've been working with it for a while, so I'm sure we can work out something.
Are you planning to create a report from similar to this and publish widely, or is this more still like?
This report is published.
Published.
This is we do these every year for the fully insured markets, so that we have going back in time, and then and then sometimes, like now, they dropped out catastrophic coverage plans because they don't want to call them insurance. So we went back and retrofitted our 2011 so you could get We also know what the rate increase is from one year to the next. It's not on this slide, but we calculate those for each of the individual markets. And so you probably will want an overview, but you'll also might be interested in some segments so you can see where it is you might be losing control, whether it's within a market or you know, different populations. So now, yes, now I'm going to turn this over to Teresa Lee.
Thank you, Linda. I think my presentation should take about 5 minutes or less. It shouldn't be very long. What I'm passing around now is the inventory of measures that we collect, both for inpatient and outpatient measures. I brought 20 copies, so I'm sure there's not enough for everyone, but Claudine has. Yeah.
For those of you on the phone, you should have received it in an email right before this meeting.
Okay, what you see before you on the slide is just a screenshot of our hospital guide, which hopefully you're all familiar with. Our hospital performance evaluation system is actually the system or infrastructure that supports both the hospital guide and it supports the HSCRC Quality-Based Reimbursement Initiative, which is part of their the HSCRC quality hospital quality initiatives and the waiver process. The collection of information, the quality of information for hospital reporting is also collected for the quality-based reimbursement program, and particularly to align with CMS requirements as of January 2014, and I'll talk a little bit about that in a couple of minutes. This slide just gives an overview of the evolution of the hospital guide, the performance evaluation system, and our quality-based reimbursement, our quality measures data center. As Ben mentioned earlier, the hospital guide was initiated in 2002, a little before Hospital Compare by CMS. And over the years, the measures have evolved. A number of measures have been added, a number retired. The inventory, the inpatient inventory that was distributed has been customized a bit to highlight in green all the measures that are currently used by HSCRC for the quality-based reimbursement program. So you can see that the number of measures currently used are not that many when we're talking about the AMI, heart failure, pneumonia, but the skip measures are still used pretty fully. There are 3 major enhancements to the system that has occurred over the past 13 years now. The first was in 2008. We required that hospitals participate in the CDC National Healthcare Safety Network surveillance system for the collection of healthcare-associated infections data. That information is highlighted on the inventory that you see. Also around that time period, we worked with HSCRC and decided that we needed to have direct access to the core measures and HCAHPS measures, which were just being created at the time. So we established the Quality Measures Data Center, which is a website for the collection of both HCAHPS and core measures data by hospitals on a quarterly basis. It is also a system that enables us to do independent chart audits of the core measures data. And it's also a vehicle for communicating with hospitals on requirements and changing requirements. We have on the QMDC website included the way in which we calculate the HCAHPS measures, because it's slightly different in terms of results from what CMS may calculate because of the timing and some other issues. So the QMDC is actually a web portal for the submission of data, but it's also a way in which we communicate with hospitals. This slide gives 2 screenshots, the hospital guide, which you saw earlier, which is on our website, and then the QMDC, which was established in 2009, as I mentioned, and that's the website where hospitals actually submit data. We're in the process of modifying significantly our approach to collecting and displaying data by pulling together the QMDC site, which was built for hospitals, and also pulling the public site, the Hospital Performance Evaluation Guide, into one place. So hospitals will go to the guide, to this website, rather, to to log in, submit their core measures, HCAHPS data, but the information that we display to the public will also be available on this public site. And we're further enhancing the system to not only have hospital data, but to also pull together the long-term care data, if there is physician information available over time, ambulatory care, our other websites will all be able to be accessed here. So there will be a single point of access for our consumers. As Ben mentioned earlier, we also added on the former slide the collection of cardiac data, specialized cardiac data through 2 registries, the NCDR Action Registry and the CAS PCI Registry, which we haven't used for public reporting as of yet, but our plans are to move that information forward to provide specialized services information to consumers, and it'll also be used for the management of our CON project with respect to cardiac CAT services that are being provided through what used to be the Commission's Waiver program. You see here is a list of the measures that are collected, and they are identified on those 2 documents. I won't go through those for the sake of time, but assume that you all are very familiar with the process of care measures. Again, as I said, the measures used by HSCRC in the QBR program are highlighted in green. We provide common medical conditions to consumers as well as maternity and newborn data from the HSCRC file. Our major initiatives are Healthcare Associated Infections Initiative, which includes the use of the CDC Healthcare Safety Network surveillance system, is an area in which we spend quite a bit of our time and resources, and we collect central line associated bloodstream infections information and have seen significant improvement among hospitals over the past 3 years, over 50% reduction in CLABSIs and ICUs. We also collect surgical site infections data for hip, knee, CABG procedures, and we're adding colon and abdominal hysterectomy, again, to be consistent with what's required by hospitals across the country by CMS under their value-based purchasing program. We will be collecting as of January 2014. We don't have that data yet, but central line is, the CAUTI and ICUs. We will be collecting multi-drug resistant MDRO information through CDC, which will include C. diff as well as MRSA bacteremia. I mentioned earlier the cardiac data that we collect. And at the end of the slide, you see data validation. That's a strong component of our work. We do independent audits, as I said, of the core measures, and we will be auditing the cardiac data as well. That concludes the presentation, and the link here is to the hospital, our hospital guide, and hopefully within the next 3 or 4 months we will have a new consumer guide for all to see. Thank you.
Any quick questions for MHCC? I know there's a lot of information, but in general, I think the way we structured that list that we distributed before was we looked at what is available already and mainly in MHCC in terms of non-hospital quality measures, and we tried to pull them together. So we are hoping that we are not going to be creating new measures for the waiver. We are just trying to leverage the existing measures and maybe create a hierarchy where we can select a group of measures that will really indicate the movements in the system, and then have a second set that we can monitor to detect any other changes. So MHCC is both the hospital measures that they collect independently, but also the long-term care measures on nursing home, home health, and maybe even the physician measures when they come in would be very effective tools for us to put it in a context of the new waiver. And then we're going to have more discussion on the total cost of care in hopefully short minutes. All right, so we have one more presentation.
User-facing services. That top one, our query portal, it's really where we started. The ability for a clinician to log in and find clinical data from across the participating hospitals and labs and radiology centers just becomes especially relevant under a global budget reimbursement methodology. That middle box is the encounter notification service, what we call ENS. That's our ability to notify a PCP in real time when one of their patients shows up at the hospital. That's being used very broadly from about 100 organizations representing almost 3 million patients. We send about 6,000 notifications a day through that infrastructure. That yellow box is our master patient index. It was alluded to a few times in previous presentations, and that's really what we're going to focus on as a core component of our reporting infrastructure. At the bottom there you see an acronym ERS, or the Encounter Reporting Services. We've evolved that to call it the CRISP Reporting Services, and we'll talk about that distinction in a moment. So the key capability we have that enables all of our services, whether it's the query service, notifications, or reporting services, is the Master Patient Index. Going back a few years ago when we did our technology procurements, Chris placed a disproportionate focus on this piece of technology to ensure that when a patient arrives at Mercy, for example, and then Johns Hopkins, that we can accurately link them, avoiding false positives, linking patients that shouldn't be linked and presenting clinical content for 2 patients as one, while keeping false negatives, missing links, to a minimum, which is the whole value of the exchange in all of our services. Doing this well is critical in the new waiver world in terms of population health, in terms of cross-entity readmission analysis, and other population-based reports that we'll touch on here coming up. Kind of take a step back to how we got into reporting. It was really through a partnership with the HCRC as they were looking at the readmission revenue model and the inability to look at inter-hospital or cross-hospital readmissions. We partnered with the HCRC based on the fact that we had already kind of collectively as a state invested in a master patient index, and that's when all hospitals started to send what are called real-time ADT messages, or admission, discharge, transfer messages. Those are the things that represent an ER registration, an observation, a transfer, a discharge. All Maryland hospitals submit those in real time to CRISP. So that's one unique aspect of those types of messages. They're real time. The second unique aspect of those messages when combined with our MPI, our Master Patient Index, is the ability to create that unique ID, that cross-entity unique ID that allows us to say that the patient that was at Mercy is the same patient that was at Hopkins. And then the last is that there's a street-level address associated with the encounter that allows a far more granular geographic analysis than previously possible when looking at HSCRC tape data or when looking at claims data. I'm going to skip ahead and then come back real quickly to this slide for those of you who can see that. When we started working with the HSCRC, the parallel question we asked is, given all of this data flowing in and the objective of assisting the HSCRC in doing cross-hospital readmission analysis, could we create a report to submit back to our participating facilities, participating hospitals? And that's what we focused on. Now, it's a relatively high-level set of data. It's encounter data. It doesn't have clinical content. But it did enable that cross-entity inter-hospital analysis. So we created basic readmission logic, which was slightly different than the ARR logic because it was inter-hospital. And we based the visit counts off of our ability to create visits from the real-time message flow. So if somebody goes to a hospital, you may have 30 ADT messages over the course of a hospitalization, from ER registration to admission to transfer to discharge. We created logic for every single hospital to turn that into an admit and discharge. And then we validated it against the HSCRC tape data to make sure we were getting it right. And we were in the high 90s in terms of our ability to create visits that accurately represent what was submitted in the tape data, but it wasn't perfect. And those two flaws, the fact that our logic was a little different, plus the fact that our visit counts were a little different, caused a lot of problems. So while this report was interesting, it wasn't perfectly aligned with how hospitals assessed themselves and how HSCRC assessed hospitals. So we'll come back to that issue in a moment. This report, quickly showing you, for those of you that can see the big screen, essentially what it's saying to a hospital: of all the patients you discharged over a 30-day time period, here's how many were readmitted, and here's who they went, and here's who they are in the context of your medical record number. So you can see the majority of hospitals were patients were readmitted back to the same hospital, but many went somewhere else. The CRISP reporting services was really developed through a partnership with DHMH on the SIM model design work. And the idea there was to incorporate the ADP data with the HSCRC tape data to create far more granular reporting capabilities. We can now do that very successfully in terms of linking the unique ID to the tape data because there are overlapping data elements, the medical record number, the facility, the zip code, the admission and discharge timestamp. So we can just add essentially one data element to the tape data that allows that cross-entity analysis. And from that, we've created this data utility, right? So now we have the data staged in that blue box, and you can apply different tools on top of it. One tool that we've been working with is called Tableau. Some of you may be familiar with it, and I'll show you a few sample reports that we've created for local health departments. The other key point here is that prior readmission report we've been distributing as an encrypted file directly to folks that we've identified at hospitals. We've developed a secure website which we can issue accounts for hospitals, local health departments, other relevant users of these data sets to be able to receive the report. So there's going to be a different methodology to distribute reports moving forward. This is a list of the types of reports when you think about that cross-entity analysis that become possible and relevant within the new waiver requirements. I'll point out a few of them, and you can see them in your slides. But cross-entity readmission analysis, which we looked at before, but now inclusive of, say, clinical service line, looking at primary service area and exclusivity and where patients are going outside of your primary service area, even if you're responsible for them as a hospital, and super utilizer information by charges, for example, where you can count within a PSA how many visits did a given patient have and how much do those visits cost. When looking at that address, that enables geocoding and an ability to map at a far more granular level, again, than previously possible when looking at just zip code-based data. So this is census tract. There is a policy question here in terms of going all the way down to address-level data and who is really allowed to see that data. But this is actual using tape data showing readmissions normalized by the underlying residents for calendar year 2012, red spots being high readmission zones. But we can do this for any data that's really in the tape data. Impossible to see unless you're back there. But the next three slides are really showing what we produced in Tableau for the 24 local health departments. This is picking their top DRGs, and the unique ability for us to do this is based on assigning that unique ID and assigning a geocode that's in that geography. And so we can say these are the top 5 DRGs that are most prevalent in your county or Baltimore City. Here's what that looks like when you look at the statewide top 5. And then cutting those by unique patients, by visits, by how many all-cause inter-hospital readmissions that happened within those various diagnosis-related groups. Next slide shows visits and readmissions by patients. So that first bar on the left is the population, with the blue on the bottom being 1%, orange being 5%. If you move to the right, that's visits, and you can see that, some of you can see, I can't see, that roughly 5% of patients represent 20% of visits, represent 50% of readmissions. And you can drill into that data through this tool if you have the right access. And this is just a visualization, again, of that data. This is the one coming out of, obviously, Baltimore City's report. This is the last slide we have. The overarching point, I think, of this data utility we've built is that it incorporates the tape data staged in a way that you can apply different tool sets, whether that's for the types of reports we outlined in that kind of menu slide, and applying predictive tool sets on top of it, or in incorporating additional data sets. Linda and Ben mentioned our work with the medical claims database, linking a unique ID to that. Now you've got a key, while both are hashed, that you can link those data sets together. So there's a lot of opportunity that comes from assigning a standard unique ID across data sets in terms of cross-data analysis. That's my timer, and that was my last point. That went well.
Great. So just one comment, you know, in our charge, we have 2 charges, right? One is what HYGIENE needs in terms of waiver and monitoring, and then we are going to quickly start thinking about care coordination and data and infrastructure. So we try to give you kind of an overview of both of those related things for both of them. So CRISP and their ability to create those reports and readmission analysis are very, very critical in the care management world that we are going to be talking in the next meeting. But their ability also to link this side of the table so that we can either improve our data systems or remedy some of the weaknesses of the claims-based, administrative-based databases with the information from CRISP is, addressing both of the charges that we have in the data work group. And I do see, linking kind of opened up a lot of resources for us. For example, we recently did analysis of the primary adult care population where they automatically became eligible after January 1. So we are, for us to be able to, we couldn't get it from our data tape because they weren't identified in our data tapes. And using CRISP as the vehicle to link with the Medicaid data, we were able to identify those individuals clearly. And looking at our data, you would think that they didn't have coverage before. They should have been self-employed in our data set. We saw that it was 50-50. They were identified as Medicaid. They were identified as private payer and self-pay. So it really helped to have such a secure link that that there is no data quality issues there. That, that link helps us to kind of trust in the data that we are looking at rather than thinking about, oh, okay, is there any data reporting issue? Is there a quality issue? So both in terms of expanding our data set, but in terms of also accuracy of the data set, we are way ahead of the curve in the nation, I think. And that's thanks to a lot of people who've been thinking about this and implementing things way before we need it. With that, so any questions to any of the presenters? I do have some. So kind of going back, it's like beginning, we talked about your website and how you link with the community, and then we have CRISP linking with the hospitals. How do you see your website functioning? Like, what is your audience and kind of the way that the data is used?
So it's really, your ordering was very good for the presentation. So I think the audience is certainly communities, but most specifically LHICs and people that work in community health in their individual jurisdictions, as well as people working at the state level. So being able, back to Ben's point about having standard measures across multiple entities, I think that's really one of the things, is that because we have so many data sources and people really measure things in a lot of different ways locally, we didn't have a ruler with which to measure many of these outcomes that we're looking at across all of the jurisdictions. So that's really one of the main utilities, is the population is for the local jurisdictions, folks working in community health, as well as working cross-sector together to look at where they are compared to the state. I think the information that CRISP has, and the network of care also, just one more note, they also bring together best practices for how you can actually use interventions to impact on these different measures. And so I think the work through SIM that we've talked a lot about, and how you can really look within a community to identify individuals that may be driving a lot of our indicators that are in the SHIP measures. I mean, these things are going to need to work together to be able to allow folks to have an opportunity to have an impact.
So you raise an issue, patient protection. If you gave my name to anyone who showed up at my door and said, I've looked at your claims data and, you're not controlling your diabetes. I mean, so what did you mean by individual patient?
So what I'm saying is, yes, there are issues around individual patient protections. I agree with you. The data that SHIP has does not provide that level of data. Obviously, what I'm saying is, well, not obviously. Sorry. What I'm saying is the people that would want to be part of a community local health improvement coalition that might be the appropriate people to address through care coordination or working with a primary care provider, linking with a hospital, understanding who the high utilizers are. Obviously, those protections would need to be in place so that information wouldn't be revealed. But I think that, with the local health department report as a starting place, and you can talk more specifically about how people have used it, but like in Worcester County, it's a really good example. They are conducting care coordination for some folks in their community that are high utilizers, and they do have protections in place where they're using information that is patient-specific to identify people and provide services to them. So Worcester has, through the CHRC, a grant. Debbie Geller has been really very proactive. I think many of us know she's the leader of our health officer. She's doing a great job. So not to raise alarms, we don't have any patient information that's on our site.
Yeah. Thank you. Yes. And just a bit of elaboration. I think that the idea of how that's all going to unfold when you talked about the master patient index, and a few of you were at a meeting last week where we really want to segment off how potentially data collected by a state entity that's not a covered entity could be shared for payment, treatment, and healthcare operations for a covered entity is something that we're going to resolve probably with a broader audience than this group, because it is very possible, because of the MPI, that it is going to be feasible to re-identify information and make it available to a covered entity for treatment. But that's going to require some involvement with our attorneys and others, including the certainly consumers who would have opinions about how that would all fall out. But clearly that's something that we need to keep in the back of the head, but I don't think this group can resolve that. I had one other question for Raquel, and clearly the SHIP areas are, with the exception of the midshore, basically county-based, with the midshore representing a consortium of 4 or 5 maybe counties. How does that, the fact that healthcare is not necessarily broken down by regional, by county boundaries or governmental boundaries, what insights can you give us to how that has worked to have one region, one area that is actually a consortium of jurisdictions, or is it too early to say?
Well, I can tell you what has happened. So there were 2 regional LHICs when we started, and now there's 1 regional LHIC because Worcester, Somerset, and Wacomico decided that it was in their best interest to work individually as opposed to regionally. Now that same request, even though it's very public that that's happened, because I gave you the slide, and it's been discussed amongst the health officers, that has not been the same request from the midshore. How it's worked, I think it is too early to tell. I think there's so much variability in people's ability to work effectively as a group looking at population health measures within their jurisdiction, and we know that utilization patterns are a little bit different than that oftentimes. So I think that we will have a lot to learn from what is working well in some jurisdictions.
If there are no other questions, I want to kind of get back from another angle with the total cost of care discussion, because the MCDB, the detail that we had, and the Medicaid discussion is kind of getting us to that, okay, we have to measure total cost of care, and we have options on, on the table. If you read some of the white papers, one option is to create a reporting mechanism for aggregate numbers from the payers, and the other option is using medical care database and augmenting it with Medicare and Medicaid files to create those numbers from the claims ground up. So I wanted to, in that discussion, first question is, what is your timeline to add Medicaid to the MCDB? And what is your general timelines in terms of the quarterly, final data? Because I think the total cost of care, even though we are reporting to CMS annually, the understanding is that we need to monitor it on a more frequent basis, because the we are not only looking at total care, but we are looking in the shift. So for us to be able to detect any shifts between providers, we probably need something more frequently than the annual reporting. So if you can jump in that one.
I would say that in order to simplify the quarterly submissions, we went from a claim runout specified to paid date, which means that at the end of a quarter it won't be all the it'll just be everything that's paid at that quarter. So you'll still, depending on how you want to define that, you know, if you were interested in the actual per capita for a certain time period for a person, you'd have to allow a certain amount of run out after when the next, you know, into the next quarter. You'd have to wait for the next quarter submission to make sure that you got complete data. Now, if you're interested in just, you know, working with, of course, let's say the first 6 months of this year and the last 6 months of last year, so that you know, you can do rolling time periods, which may be sort of the best way to do it. You'll say, okay, we know that we have, you know, 90% of the claims now, or 93. I mean, it can take a really long time to get 100% of the claims. So you pick what you think is a safe one, and then you can do that on a rolling basis. I think our plan is, you know, that at some point we will have an annual constructed when we haven't talked exactly about that, because we're mostly, you know, eager to just see it flow in quarterly, and then, you know, we're trying not to have expectations beyond just getting the data on a quarterly basis and making sure that they're able to, that the data makes sense. We actually, it turns out there are all kinds of things to worry about if you do rolling time periods. We just had an interview with an actuary who said you actually have to worry about the number of business days in a month, because the number of days that people have to be able to go to a provider influence the volume. So once you stop doing a year, you have to worry about general seasonality. If people don't want to go to the doctor in December, if they can avoid it, you have to worry about number of business days that are available for people to look at the claims. So I think you can do what you want to do, but when you do that, there are many, many more considerations that you have to take into place that influence what's happening in any particular month on a monthly basis, as opposed to a year.
What are you thinking about in terms of? So, for example, in terms of timeliness, we have to produce the baseline information calendar year 13 by May or June. So would the medical claim database will give that information in time for us, or do we need to find other ways to collect that information, or do we need to go to CMS and say we need more time? So that's kind of the level of, so that's kind of a concrete example. Then moving forward on a quarterly basis, then we need to, Medicare is going to have 3-month run-out period for us. So that's kind of, ideally, if we can line up with the Medicare, that will be the easiest way to do it. But the question is timeliness. How much importance do you put on timeliness versus completeness of the data in a calculation like this?
So, Linda, maybe you can outline the let's say hypothetically, the 2014 calendar year data with a claim based on claim paid date would be available in May of 2015?
Yeah, I'm thinking May of 2015. Some of how fast the quarterly data will get, we're not giving them, at the end of the quarter, we're giving them very little time to turn it around and submit it. We do have to build in a little time to maybe get an ID from Chris. And there are big questions around how long that process could take. If for no other reason than because of carrier lack of compliance with what's required. So I mean, they can drag that process out, beyond, a few days to weeks and weeks just by, if it's not complete. So there'll be a learning curve there. So I would hate to say, I'm hoping that first performance, but so you would be, if you figure 3-month claim run out and you figure that's our quarterly data. So with the first quarter submission from 2015 would be when you would get your full, you would have an analogous 3-month claim run out, and you would call that your year. And so that's the end of March, and then I think we give them until the end of May to submit. And then you're going to want our database vendor to clean it up for you.
So, I mean, I think that's that's a rosy scenario of given there are a host of new submitters, and it should be known that recently there's some evidence that some of the new submitters that are not subject to state regulation have taken a more aggressive approach or a more intransigent approach to submission in some states. There are, fortunately, in states that are not in the same federal circuit as Maryland. So some of the recent decisions affecting mandatory submission on entities that are not covered by state law don't affect us at this point. But I think that's Linda's hesitancy is based on some sense that willingness to do this is changing. To Maryland's favor, however, I think there's a lot more impetus to being a good corporate partner here than in some states, which may compel even some national firms that may not like the fact that they're being regulated by the state or compelled by the state to do something, to actually cooperate. And in some instances, those entities have very significant state contracts that might cause them to pause. So I think Linda's trepidation is based on sort of a view of what the landscape's looking like, and a shifting of some of the carriers, not the Care First, United Healthcares of the world, but others that typically have not submitted in Maryland.
Just to be clear, so I don't see that database being useful if we have to develop a calendar year 2013 baseline within a few months.
Right.
So,
well, it's true. Our 2013 data won't arrive until this summer.
Yeah, I mean, it's a stretch even for all of
us. But that's only because
2013.
That's because it's under the old submission rules.
But even if you have it, Medicaid, we would need to work with Medicaid to get their numbers differently, right? They are not included in your data set.
No.
Now for 2013.
Right. When is that link is going to happen, that if they're going to come in under MCDB?
We think that we're waiting to officially start the data flows until MMIS 3, I think. Right now they're doing a project for us where Laura's working on that, where they're making Medicaid-like files. But I think our issue is, we're looking for complete utilization by patients that are sort of analogous to the privately insured, so you have good comparability and you can compare their utilization and their rates. Whereas you want total programmatic. So we're not collecting the fee-for-service. That's not part of we're really focusing on the MCOs because in the fee-for-service it's mostly the duals, and they're a challenge to understand, right? I mean, we're getting the fee-for-service information for the MCOs so that we'll have complete and total spending on the 80% that are in MCOs, but you still have your 20%.
So then going back to getting the base year data and try to get more aggregate level data, we prepared a template for just kind of to start the discussion, and it's based on the Medicaid reports. It seems to me that, the claims level data is going to be important doing other analytics and measuring other things, but we seem to have
So just
or
before
learning.
before we leave the 2013, when do we think the complete 2013 would be available in our best case scenario?
I think we've said the total database cleaned and ready to go. I think we're thinking November. I think that's what we've been saying. November.
That would be consistent with sort of the most recent, the 2012, right? So
that would be consistent with our reasoning.
Not really, and that's not changing anything yet. That's not, of course, the automated data collection. So I think
right, that's the old system.
November 2014, maybe a bit earlier, but not much.
Yeah, I don't think so. Just there are lots of activities that have to go on. But I do want to point out that the accelerated data isn't only needed by you; it's needed by the Maryland Insurance Administration. Their priority is probably on making sure they get clean data. You know, so there's a trade-off, right? I mean, which we're all very familiar with, which is that speedy is dirty, and really clean data takes, it can take a really long time. So you have to find that trade-off where you're comfortable with the quality and you can live with the timeline. So, but the 2013 we're thinking would be ready in November, and then we're hoping that as we said, that we would have at least the first, the MIA is willing to take it on a rolling quarterly basis. So, and that's the, once you get, so that you don't have to wait for the end of the year to be compiled. It can be sort of compiled on the fly, if you know what I mean.
Yeah, and so it's also important to keep in mind that for 2013, it's going to be quite a bit more complete because it's on, as of April 30th, all claims paid for 2013, whereas in 2014 we pivot to this claims paid in the quarter. So in essence, and this will be a bridge issue for from 2013 to 2014, that you may actually see a decline, if not adjusted for. You may see a decline in spending that's completely an artifact of the new data collection rules.
So we'll summarize these decision points for you in the next meeting in terms of timeliness, completeness, run-out period, for us to be able to see those two options. But my sense is we should also consider the aggregate ones, the option that was proposed in the white papers. And, we'll see, but it seems to me that we would need this kind of information regardless of where we are with the claims database to have the totals and then have that kind of a level of the redundancy in the system so we can check the numbers from both sources and make sure they make sense. So in this table, I basically, so since we are also looking at the shift in care, the level of detail, I put it as county. So you may want to think about if you are looking at the shift in the care, is county enough? And as Ben pointed out, county boundaries are imposed on, administratively, and it may not reflect the real boundaries. If you go to zip code level, that will then create detail level that may be harder to get for the payer. So that's kind of the trade-off there. And then we have age and sex breakdowns here, so we can see different, that will give us kind of different service line breakdowns without really specifying them. And there might be other information that you would want from the plan level, like the individual market or the self-employed, so that we are also looking at the enrollment trends and controlling for those while looking at the data. So if suddenly there's a big shift to the individual market, at the aggregate you would see changes in the total care, but it's just because the enrollment patterns changed, not because the provider practices changed.
So I haven't read the white paper, but much more than an aggregate data report strikes me as enormously challenging for many carriers to construct. And would be enormously challenging for how that would actually be used. Keep in mind that Linda's point about 50% of the pharmacy market is delivered by PBMs. So they would have everything blank but the pharmacy side of things. And also, I mean, I think that developing some proxies, and what better proxy would be to say, I suppose, what does the, a couple of the carriers fully insured market segments look like. So Aetna, United, Care First have fully insured business in Maryland, and so they would capture that completely. Cigna, I think, not a lot of Maryland regulated business. Mostly your business is self-insured, so it might be some business might be carved out of those products. You can't tell, but you'd have to, if you contemplate this, I think you really would have to come up with some sort of proxy measures, especially if you went to the county level. This will give a lot of people pause. I would think it's developing the specifications for such reports are not necessarily trivial items either.
Right. I agree with you. It is also, it's not an easy solution, but I think in terms of the pharmacy versus dental, your discussion to me is in the Medicare one, first of all, drugs are not included in the total cost of care. So if we feel that we don't have complete data, I think for initial years, it is okay to say, okay, our total cost measure excludes this, because we haven't collected, we are working on collecting that data. So I don't see that as a big barrier as long as we are clear on what is included in the data and how big that portion is. The county level detail is important for us to be able to link that with the special providers. And in the Care First wrote one of those papers, we need to describe what our expectation is in terms of what reports will be included in, right? What businesses, self-insured, whatnot. But and we are not looking for the 100% either. I think if we get a good sample, as you pointed out, a good sample from the state, that may be enough for us to be able to look at the growth rate, because we are not too much interested in the actual dollar amount. We are interested in the changes in the trends and the growth. So that, I think, we should always keep in mind in looking at it and try to minimize the burden on the payers to produce these level of reports, and also be very mindful about the top row here, the distribution, the hospital, inpatient, outpatient, emergency, not emergency. I think that's the key for us to be really get it right at the beginning, so that we don't go back and say, oh, really, we specialty care, do we really need to break it down, or is it okay for us to have that? I think that's maybe we need to create a separate, from the payer representatives, a separate small work group to work these details and bring back to you, and then get your opinion into hearing what is doable from their perspective and what we think is required from the waiver perspective.
So just to comment too, I mean, this is something that we require of our 7 MCOs right now. So it's not unheard of that a payer could do it. We require it. We've required it for a long time. They have to submit these types of, and this level of detail. There's, I don't know if it's by county or by region in which we set the rates, but they're required to submit data to us twice a year, and we roll this up into an aggregate level. So we get it by MCO and an aggregate level. Obviously, I would assume that you could break this out across service level in terms of expenses. I mean, I'm sure all payers are monitoring, very closely to set rates.
I would agree with you.
Yeah. So some of these unique things about age and sex, that might be unique to our rate setting, but you probably do it by product line. So I think it's not unheard of and can be doable.
Right. I think if you bring the group of people who are really in the trenches, I'm hoping we can get a basic template that will be relatively easy for everyone to produce.
And Tricia, do you know what the MCOs and the payers submit to the insurance department? There's probably another set of financial reports they have to submit at least annually, if not more frequently, to the insurance department.
Right. That's correct.
Mm-hmm.
Yeah. So that's a point of reference that those reports, when we've tried to benchmark them, have been they don't align too well, even when we've been very specific on isolating product lines.
Yeah, we did quick look at them before this meeting. Maybe we are not looking in the right reports, but they didn't have detailed information as broken down by service line, so that was kind of why we didn't bring in front of you. But we can go back to them again, kind of dig deep and see if there are any relevant reports we can at least base it on and then build up on it.
Can I ask a question here on this one? And I'm not the best one to ask this to without putting anybody on the spot. One category that I think might be missing is other outpatient. We have hospital outpatient, and then we go right to primary care and specialty care. I don't know if other outpatient is included on any of the reporting that's currently required, but that seems like a category that might be a big bucket.
We can, as long as you define the provider type and setting that you're talking about, we can.
Right. You can do a whole set of just post-acute care. You could have SNF, home health, various sorts of things.
Ambulatory surgery.
I mean, yeah. I mean, depending on how you want to break out your provider types, I've got a Medicare background, so my preference would be Medicare payment methodologies, which would be, you've got all different types of inpatient.
Yeah.
Right? It could be inpatient psych, inpatient acute, rehab, long-term care. So it just, what level of refinement do you want to go to?
Right.
And this is, again, this is modeled off of our Health Choice product that doesn't enroll individuals 65 plus. So there's a reason why you don't have some of those type of service lines included in this.
But to Tracy's point, I think that the more detail that we could get, the better in terms of the services. So if there were codes or options that we could look at and say, okay, well, we want to see, we want ambulatory surgery broken out versus imaging services or home health, that sort of thing, that would be great.
I absolutely don't disagree. I don't disagree. It's just that the more granular you get, the more work is involved, and the more understanding. Okay, not that it's not impossible, but, I'm sure the gentleman from CRISP can speak to some of the issues with, and also Medicaid, the issues you have with provider masters, what have you.
So, I mean, one of the challenges for us, although we are collecting this for 80% of our population, there is still a portion that are in the fee-for-service program. Also, not all the services to the MCO population are served under the managed care program. We've got dental, we've got, behavioral health that are all carved out. So tying these things together to get a per person will be difficult. It's not going to be easy, but it definitely probably has a purpose in at least the short term.
And in terms of this level of detail, we don't really need to tie at the individual level, right? This is kind of getting the totals and make sure that our denominators are counted. So if you have, it's a good point, if you have different denominators, once you aggregate them, it's important to carry them forward too. So if you have carve-outs, right, then I won't be able to use my MCO denominator for some of these buckets that I will be aggregating at the end. So whatever the coverage that you have, you need to make sure you're carrying the denominator accordingly to that bucket. But not in terms of identifying, okay, should I tell as a patient what is their total cost. We are trying to aggregate it at the service level and then using the aggregate denominators, creating the per capita count. So that should give us help a little bit, I would think.
Yeah, if you don't care about the type of population, I mean, if you're just looking at overall Medicaid across, there's probably a way to do that. But if you're looking at disabled, and if you're looking at any type of breakdown, then it becomes challenging.
I mean, you need to consider the breakdowns, but I don't think that it's necessarily we need that level of detail on the breakdowns.
Right, but I think when you start thinking about breakdowns, I think there are some reasonably well-established guidelines already out there in the industry. I've seen them in Medicare. I think if I was going to break down a Medicare population, I'd break it down in terms of chronic disease states, mental illness states, people with disabilities, because you're going to have those in your Medicare, and then just the rest of the population. So you have 4 different breakdowns of your membership because they're going to require different interventions. Right? They're really going to require different interventions. So I think what you're trying to really establish and set up, because I constantly, I think back to the kickoff meeting that we had at Maryland Hospital Association. And I know how critical total cost of care is. And then I think of the kickoff meeting, and I believe it was Donna Kinzer did a presentation from the advisory group. And one of the bullet points, what were the important things to keep in mind as we move down this road? And it just keeps jumping into my mind, and it's kind of, what are the initial targets? And total cost of care is clearly a target, but that's like a phase 2 target in my mind, and that's just my opinion. First targets are the Medicare savings in 358 and those sorts of things. And how do you kind of move through these first few years, and particularly these first couple of years, to kind of tee up and stage and get everybody on the same page and the same conversation about how do you actually get to that population health care management.
Yeah, I think in thinking about this, that reminds me, we are focusing on the current needs, but we need to think about the phase 2. So if you have that detailed breakdown already in the works, that will help us in terms of planning for phase 2 and understanding some of the dynamics too. Yeah, I think it's a great point.
Yeah, because different members, different intervention.
Right.
Different, a PCP intervention
right.
works for somebody who's pretty healthy, but if they've got a disability or if they've got, mental health conditions, completely different interventions are required.
Surely. So I'm just to make sure I understand. Are you thinking that for privately insured claims that you want to use the MCDB database, or you're going to work with? You said you were thinking about getting a payer work group together. Which?
Yeah. Since we need to work on the 13 baseline really quickly, and there might be other, even with the 14 data, since they are starting the quarterly recently, I think we need to put our eggs in 2 different baskets for the time being. And eventually, I kind of see the analogy of our case mix data and the financial data, where you have the financial aggregate, and we kind of align it and check it with the case mix data, which is patient-level data. I think we can create a similar relationship if we start collecting an aggregate level from payers. But we need to work with a few folks from each payer who could help us in drafting the templates and specifications, and think through with us, who would be submitting that information on a, what timeline. And then, since we are a large group, I thought that it will be more efficient if we bring those Y sets together and then get to you kind of, okay, this is what they think they can come up with, and get your feedback that way, so that we don't go through detail, one by one here. So we're going to do both.
Gotcha.
All right. But at the same time, in our report in April, your ideas about, I got the more detailed is better, but cautious of the burden. Think about the phase 2. So kind of these guiding principles in terms of this total cost of care will be added to the work group report that you all are going to be reviewing and helping us edit. And those are kind of our guiding principles and things that you advise us to think through this process. All right. So we'll, think about this. If you have any comments, please send it to us. Don't wait for the next meeting. And we'll try to quickly get another group together, a subgroup, if you will, and see how far we can get with them on as quickly as possible. So I think we have time, right? So before we move in, it wasn't on the agenda, but the provider information. Ben mentioned the surveys that you were doing, and I was wondering if you were trying to get at the participation in ACOs, medical homes. I think we again have an alternative there. We can go to the payers, Care First, give us what the number of physicians you have in medical homes, go to Kaiser, get those information somehow, and then we need to deduplicate it and find the denominator and whatnot. Or is there a way that you think we can do it through the surveys that you implement?
So keep in mind that these are biannual. So you're not actually capturing real-time participation on some things. Don't change over time or change very intermittently, specialty, for example. But participation in other initiatives do, and I think that's probably the information that we could collect on a biannual survey is not going to be as pointed as you probably would like. You could get some idea. For example, we have added recently for primary care. Do you have a concierge practice, which has diminished the availability of primary care physicians to all insured populations. If they want to pay, they don't want to pay the burden. But it's something that can be done, but I would rather suggest that there is something closer to a real-time arrangement. The P360 data that United has provided can I think provide a more accurate reporting on network participation in terms of some of these new payment entities, ACO participation, etc. There's only a dozen. It might be easier simply to survey those directly on ACO participation because they would have the best information available. Not sure necessarily other data sources that exist. I mean, clearly, our experience with the payer networks, which is something Optum has, I think Optum has confirmed, is that carriers' networks themselves are not always up to date, and it can percolate through the system. But the advantage with P360 is it's brought together by someone else. Assembling this is expensive and complex, and I don't think if we can reach a favorable arrangement and want something in close to real time, and the exchange is continuing to use that, and CRISP has promised to make it available for free, then no, they have not made, I don't know what the arrangement is, but at a low cost, that would be the most timely information I think that we could hope to get. Surveying payers directly is on a does require then someone reconciling it, and that would be us. And I think with all the things we're doing with little increase in funding, that it probably would be too much. I think there's been some kinks worked out in the P360 system already because of its use on the exchange. Initially, there were some problems, but I think they've been rectified. And actually, if people want to go and look at it, it actually, as a research tool, can be used. I was able, with about a half an hour's worth of work, I was able to confirm network participation among the various MCOs in Montgomery County. I just wanted to look at how many primary care physicians participated in one or more MCO in Montgomery County, and came up with that answer fairly quickly. So I think I would suggest existing data sources if an arrangement can be worked out. It's not going to be everything, but it's going to be pretty darn timely. I don't know if Chris has anything to add to that.
Yeah, just to make sure everyone has a picture of what we're doing with the provider directory. We receive lists of providers who belong to a particular health plan through the health benefit exchange, and then Optum helps us put those together so that we have one big provider directory which shows which health plans a provider accepts. That's the main purpose of that. It does get scrubbed against their P360 data source, and we'd love to use it for other things. There is some of what you already said, Tricia, about the accuracy of it is still applies, but the data that Optum made some data available to MHCC, I think, is a goodwill gesture, and they want to continue to do the other stuff they're doing with us, so maybe they would continue to do that at a not too high a cost. There may be other ways that we could use the provider directory that gets assembled through the health benefit exchange to accomplish that as well. We'd be happy to try it. We are counting on the folks over there, the health benefit exchange, still using the provider directory for that to get paid for.
So I mean, I think that in terms of our focus is on a very deep drill down on what health professionals are doing, but so hours of care, location, sites of practice, the context of practice, but sort of the basic information that you suggest you're looking at. Are you in a network? Are you in a PCMH program? Whatever. The PCMH programs are so broadly conceived that it doesn't necessarily tell you all that much. ACOs, especially as we're in this period of transition, I would be uncomfortable saying, yeah, that guy was in a ACO 2 years ago when he last renewed his license, or that girl. But can't guarantee to you today that that's accurate. To go to the other length, which is to sort of have the board agree to on an ongoing basis, update this, would be a hurdle, I think, that would be too challenging for them to undertake.
Are those measures really a priority, though? I mean, for CMS?
They are in the monitoring list, and we don't have any timeline. We can kind of...
Wouldn't ACO participation be something that CMS would have, since it's their program?
They want us to report the information that they have already. And that there are other measures there that is the same thing, like the inpatient, outpatient quality reporting that they do. They want us to report on Maryland hospitals specifically, so they can kind of look at it in a more broader way. But that doesn't mean that we cannot ask Medicare to give that information to us. So, I mean, ACOs, I'm not that concerned. The medical homes, I think the idea is for us to get a better picture of the systematic changes in the healthcare system. And these are something, I don't think they're going to be overnight, and we don't need them tomorrow, but we need to start planning and evaluating the alternatives. And, by year 2, 3, we probably need them. All right. So we can now see if there are any other questions from the work group members or any other comments you would like to make.
Anyone from online listeners?
Yeah, I guess just one comment. You were talking about having the payers report expenditures by the service categories that you had in your Excel sheet. And I think the challenge with that is, just being sure that they were all doing it the same way and, have the resources to do that accurately. We have developed methodology that we use where we basically look at procedure codes on professional claims and revenue codes on institutional claims to bucket institutional claims into about, I think it's 16 categories, and professional claims into about 28 categories using kind of a hierarchy. So if there's a ER visit and then the patient gets admitted, we'll count that as an inpatient stay as opposed to an ER visit, and have similar methodologies, again, for all the services. So if you'd like the next meeting, I could gladly share that, and that might be something you might want to consider. We do have a little bit more detail than you shared on inpatient and outpatient to try to group services with comparable costs into what we're calling the same category of service. That was it. I just can offer that up if you'd like to see it at the next work group meeting. Did you hear that okay, or is everybody still there?
They must have hung up.
Okay. So you're on the phone and you can hear me okay?
I can hear you, but I guess the webinar. Let me see if there's a webinar off too. Yeah, that's kind of strange.
Yeah. Okay. I guess we're done.